Now we're moving into stimulants. And stimulants can be broadly classified by two different kinds. We have sort of our naturally occurring stimulants and then synthetic stimulants. So naturally occurring types of stimulants include cat, ephedra, caffeine, tobacco, cocaine. But then we have our synthetic stimulants that include amphetamines, methylphenidate, MDMA, commonly referred to as ecstasy, bupropion, which is an antidepressant, and cathinones, sometimes referred to as bath salts. So when looking at what stimulants do when someone consumes them, and this is often more so if someone's consuming high doses of stimulants with an effort to become intoxicated, but intoxication will cause an increase in attention, increase in wakefulness, anorexia or reduction in appetite, feelings of euphoria. It also will increase your metabolic rate. So your heart rate goes up, your body temperature goes up, your respiratory rate increases. And as you can imagine, withdrawal kind of has the opposite, right? So people can feel extreme thirst and hunger. They have difficulty concentrating. They can experience severe depression and suicidality. It can also cause rebounding feelings of anxiety, difficulty sleeping, as well as fatigue. So it can be a really unpleasant withdrawal experience as well. Now, when thinking about intoxication of stimulants and how to manage, a lot of it is really supportive care. So monitoring vital signs and treating as appropriate. One of the things that we see because of that increase in metabolic rate, sorry, I have a hair on there is a cat hair on my microphone, increases in that metabolic rate, muscle contraction and activity, there is a risk of what we call rhabdomyolysis, so that breakdown of muscle tissue. So hydration can be helpful in reducing some of that risk. If someone presents with severe anxiety or agitation, even seizures, we can use benzodiazepines to help manage that. Acute psychosis can also happen as a result of stimulant intoxication. We can utilize antipsychotics to help treat those symptoms. In most cases, psychosis will, what we call clear, will resolve fairly quickly. But there are definitely people who, for example, people who've used cocaine chronically or methamphetamine chronically can actually have chronic psychosis caused by that chronic stimulant use. So that can happen as well. People will also report things like feeling very sweaty, chest pain or tightness. They can become irritable, disoriented, have altered mental status. So it can be a very unpleasant experience for people if they're acutely intoxicated. Now, when we're thinking about stimulant use disorder, this is kind of a more emerging field in terms of treatment options and guidelines and recommendations. So in the last 5 to 10 years, we've had a bit more clarity on especially medication interventions that may confer benefit in managing individuals who have stimulant use disorder. Psychosocial interventions are still considered our first line intervention for maintaining abstinence from stimulants, with one of the primary components being contingency management. So we've talked about earlier in-person lecture, but contingency management allows for essentially reward for not using. So things like money, grocery cards, etc. And that actually is one of the more beneficial interventions that we can offer. We also have things like behavioral therapy, support groups, and 12-step programs. And then during our acute withdrawal, we want to try to get them through that period, especially since it can be a very low feeling period for individuals, and just be supportive, offering safety, and addressing any other issues that can contribute to their experience with their substance use disorder and their success with maintaining abstinence. So things like psychosocial stressors, other psychiatric illnesses that are maybe undertreated or inadequately addressed. So when it comes to pharmacotherapy for stimulant use disorder, there's a couple different types of options. So we have our non-controlled stimulants and non-stimulants. And then we have our stimulants that are things like methylphenidate and amphetamine products. And they all kind of have slightly different suggested roles. These are all pretty still low-level evidence, but the ACM AAP guidelines that were recently published actually provided a bit more detail in terms of the level of recommendation and the specifics of the population that may be more likely to benefit from using the products, which has been kind of helpful in elucidating kind of when and where to use some of these potential agents to help support people with stimulant use disorder. So bupropion, being a stimulant in and of itself, can be potentially beneficial in managing stimulant use disorder. Now, there's low level evidence, but seems to have some potential for benefit in cocaine as well as amphetamine use, especially if there's other good reasons to use bupropion. So, for example, if someone has nicotine use, so there was a brand name Zyban that was actually FDA approved for tobacco cessation. We do use bupropion for tobacco cessation. And if someone has major depressive disorder concomitant with their stimulant use disorder, bupropion can be a really good option. Bupropion mixed with naltrexone does also have some evidence, pretty decent evidence for amphetamine use, particularly if there's concurrent alcohol, nicotine use, and or depression. Topiramate does have a low level of evidence for both cocaine and amphetamine use, especially if alcohol use is also present. So if you remember back to alcohol use, that is a product that we can use there too. Mirtazapine, if they have depression, and amphetamine use has some low level evidence too. Now, looking into our controlled stimulant products, we have modafinil that has a very specific low-level evidence suggestion for cocaine use if it's not in the presence of alcohol use. Now, the combination of cocaine and alcohol is fairly common, and actually alcohol can change the metabolism and kinetics of cocaine, resulting in a metabolite called cocaethylene that has a longer duration of action than cocaine itself, because cocaine actually has a pretty short duration of action. And the challenge with that, though, is also causes production of methanol, which can be toxic. But people will often combine cocaine and alcohol to help prolong some of the effects of the cocaine itself. So for individuals that do that, there's not really good evidence that modafinil can be helpful, but if it's isolated cocaine use, there is a low level of evidence. With topiramate, you can also combine it with amphetamine salts for individuals that have stimulant use disorder, particularly if they have co-occurring alcohol or use disorder or ADHD. Our longer-acting amphetamines for things like cocaine use, especially if they have that co-occurring ADHD. But for these stimulants, it should be considered that they may require higher doses than what is typically used for treating ADHD by itself. There's also a low level of evidence for our longer-acting methylphenidate products in amphetamine use. Same thing, may require higher doses for benefit, consider for individuals who have co-occurring ADHD. But there's still some controversy about the use of stimulants to treat stimulant use disorder, which makes sense that finding that judicious use, good monitoring, good trust and rapport with your provider and the individual who's trying to manage their stimulant use disorder. There's still a lot of gray area, a lot of challenge in knowing exactly how to best help individuals with stimulant use disorder. It's still a fairly kind of early iteration of guidelines and recommendations for that management.